It's my pleasure to introduce our next speaker, Jamal McClendon, who will be speaking on addressing pediatric thoracolumbar deformity and lumbar deformities.
Thanks, Lionel, for the introduction. Also, thanks, Kyle and Lee, for inviting me back again. Great, so today I'm going to be addressing, and there is some overlap, obviously, with this presentation and some of the other presentations that we've had for the last couple days. My name is Jamal McClendon. I'm one of the neurosurgeons at the Phoenix Children's Hospital in addition to Mayo Clinic, so thank you. And I do not have any disclosures. So the purpose of today is talk a little bit about some of the nuances and some of the treatment modalities and considerations that I have for addressing lumbar deformity and deformities involving the thoracolumbar junction. Review some safety mechanisms in addition to discuss a little bit about the nuances of treatment. So this is just a case illustration of a 17-year-old who initially presented to the office in the clinic. You know, they initially presented when they were 16. They had a small deformity here. Now they were a junior in high school, and we decided to kind of follow them in time, and then ultimately they had a little bit of a progression during their senior year, and the consideration to try to figure out is, you know, what to do for this patient that, you know, in the next year they're going to go off to college and then may or may not be lost to follow up or move out of the state. How do we really address and treat these patients? Do we consider treatment from a surgical perspective, and if we do, anterior or posterior, or other considerations that we've discussed? A little bit different than this 16-year-old that was initially lost to follow-up, initially from the pre-COVID times. We addressed a surgical treatment modality for them, and they presented post-COVID with a pretty significant deformity, and we'll talk a little bit about applications of intraoperative or preoperative tractioning and other things which may or may not obviate the need for any osteotomy work. And this is ultimately the treatment modality we decided relatively recently. So just kind of highlighting some of the previous lectures that we've had. I was fortunate to be asked to present about fusion levels in AIS, and we discussed a little bit about selective versus non-selective fusions historically. Then we kind of transitioned to where we consider stopping our implants and our instrumentations and looking at saving distal fusion levels and selective fusions, as we mentioned. Last touch vertebra or stable vertebra -1, and kind of went over and highlighting various nuances in treatment of that. And then we've extrapolated on to thinking of emerging technologies and new technologies for treating pediatric deformities, particularly as it relates to some of the anterior vertebral body tethering when Dr. Lawnard visited us last year. And thinking of the early onset deformities, whether it's magnetically adjusted growing constructs or the traditional growing constructs, following patients in time and ultimately deciding when we're going to treat these patients with definitive fusions. But today, we're going to speak a little bit about addressing the lumbar deformities. Very clearly over time, there's been a little bit of a transition and a shift for ultimate treatments for these conditions, particularly in the AIS population. We've transitioned a lot from some of the anterior-based constructs to some of the more posterior-based constructs for treatment as it looks over a kind of a 20-year window or 20-year period, to which we're now doing a lot of posterior-based constructs for the AIS deformity. A little bit more straightforward when we look at the 1A patients, the 1A minus or the 1A plus or the 1AN as far as treatment for their spinal deformity, particularly in the adolescent population, where as we've evolved and moved towards more posterior-based constructs, what we consider as far as treatment. But when I was putting together this talk, it struck me that even though we're treating patients who are adolescents and pediatric patients, what about the patients that don't end up having their spinal deformity as children? They go on and live very successful lives, and then they come back to us with some of the more degenerative sort of conditions that alter their quality of life. When we talk to them about treatment, particularly in the lumbar spine, and stabilizing their spine and potentially altering their range of motion, whereas this 58-year-old female who is an avid skier that lives in Colorado that skis 5 days a week during her year and has a child that's just going off to college, did we not do her justice by not fusing her when she was younger versus considering a fusion now, to which she ultimately decided to have a relatively straightforward surgery, an open procedure, and is still back to, I allowed her to go back to skiing the following year. And I consider the same sort of concept, particularly with Dr. Fessler being in our audience today, And over time, this is a very similar patient who had an AIS deformity that progressed during their adulthood and had a disc herniation. Are there considerations for MIS techniques that we can utilize? So from the previous patient who had an open procedure, can we think of a minimally invasive technique or a minimally invasive option through an all-posterior approach to achieve a very similar result, which I felt pretty happy and pretty satisfied with this. But for the purpose of our discussion today, what are we really focusing on is the addressing the pediatric deformities really in the lumbar spine and ultimately coming up with good solutions for their ultimate, so they don't have a significant progression, they can live with a can live without having a significant impairment. So it really comes down to the decision making and what the patient wants and our anecdotal experience. We educate the patients, we establish expectations, and we think of, do we have clinical pathways to help guide them? We overall go over their patient health, their bone quality, thinking about whether it's a soft deformity, a smooth deformity, a rigid deformity, and can we come up with different strategies, whether it's from an anterior approach, a posterior approach, or whether we need intraoperative traction based on the magnitude and the severity of the complexity of the spinal issues. Very clearly, there was a lot of advocates that were pro-anterior-based operations, particularly because we can actually save significant number of motion levels by approaching the spine from an anterior approach. And this was a very significant article that was done in 2019, looking at 75 patients with these lanky C, 5C, and 6C curves treated with anterior fusions with 2-year follow-up that had very successful and very beneficial results, really highlighting the pro-advocacy for anterior-based surgery. Whereas Dr. Lenke and his group and Dr. Bridwell did have a follow-up study actually comparing anterior spinal fusions and posterior spinal fusions a little bit later on, showing the beneficial aspects of reduced operating room time, lower blood loss during their surgeries, and a significant increased efficiency as well. That being said, there is a lot of advocates for the anterior approach. Absolutely transitioned a little bit from the single rod technique to the 2-rod technique that was initially popularized, and now looking at treatment for lumbar deformity from an anterior approach, which actually has less blood loss compared to the anterior thoracoscopic approach or the anterior thoracotomies that were done, really dealing with the thoracolumbar and the anterior lumbar operations that have been quite successful and quite favorable. So how do we make a decision? It's not uncommon, particularly in the kind of the region which I'm in and kind of the Scottsdale area, for us to consider all posterior approach just based on the patient's desires and the patient's wishes. The 19-year-old that comes to us who's just about to go off to college at one of the universities, who we have these discussions with and we follow them over time, particularly when we consider anterior-based operations or posterior-based operations. Oftentimes they're more likely to choose a posterior-based operation. We've talked a lot about the different strategies for us to place instrumentation, whether it's intraoperative neuronavigation, whether it's open freehand technique, whether it's VR, AR, or different strategies. We ultimately can come up with a good solution as far as treatment for these patients, particularly with the strength of our instrumentation. Not to be said, alternatively, there is a lot of things that must go on, particularly when we're changing the populations, particularly for the neuromuscular deformities as far as ultimate treatment. The cerebral palsies, the neuromuscular, the myelomeningocele, the spinal muscular atrophy patients all take into other considerations as far as whether we're going to address them from an anterior or posterior approach. A lot of times, based on the need to do combined or even stage surgeries, a lot of times, at least at our institution, we're choosing to really address these patients from an all posterior approach based on efficiency. It's not uncommon at our institution where we use 2 surgeons to help with the efficiency of the operation, but also taking into consideration of what the literature has discussed. A lot of times with the combined approach or even the staged approach, even though the major complication rates have been relatively low, particularly from the anterior approach, just from an efficiency perspective and an efficiency standpoint, there may be significant benefits of approaching these patients from an all posterior based construct. This ultimately allows for improvement of their sitting balance, allows for curve progression, prevention of curve progression, and then also it prevents the organ impairment or have any considerations or concerns for additional organ impairment just based on approach-related morbidity. You can see just from these highlighted examples that there are several different individuals that we've approached, all from a posterior approach where good is good, and certainly we can improve that if we would consider a combined or a staged approach, but for these individuals, this was very good or good enough for them to have improve their sitting balance and allow for prevention of organ impairment. For the congenital population, I'm not sure that we've fully figured out, particularly for the early onset deformity, whether approaching it from the growing spine, if we are actually restricting the ultimate lung capacity or the forced vital capacities, particularly for the growing thoracic region, even though it hasn't truly been studied. Are we doing ourselves a disservice for not approaching these from an anterior perspective? This was a 3-year-old example in which we considered, a multi-level vertebral column resection for that had some screw implant and screw prominence that was seen here, ultimately requiring a revision. And so I did ask myself the question of, did we do ourselves a disservice by not approaching this patient from an anterior approach? That being said, because of their age, I suspect that they're going to need additional surgery moving forward as well, particularly based on the challenge with these particular implants as they were on a 3-year-old. So taking into consideration operating room efficiency, it is imperative and important when deciding how to address these lumbar and thoracolumbar deformities, how we can actually it takes into consideration of how we address these deformities. You can see that this surgical duration being a little bit on the shorter side, there's a lot of opportunity for us to even improve upon this, particularly as it relates to operating room efficiency. This is a syndromic patient that we followed in time as well, whereas we initially started by bracing this particular patient and thinking about whether this deformity does progress or not, initially starting with bracing to allow for skeletal growth. We don't necessarily always have to consider operations or surgical interventions. We can actually follow them with a brace to address the deformity. But at least in our perspective, a lot of the times when we think of posterior-only approach based on the strength of the instrumentation, the type of implants that we have, we tend to bias ourselves towards a more favorable or biasing ourselves to consideration of operating on these patients through a posterior surgery. The significant correction that we can obtain with tractioning and with intraoperative and also confirming safety with intraoperative neuromonitoring has allowed us to approach this all posteriorly. There's been a significant amount of literature which discuss preoperative tractioning. We know that from some of the earlier studies in 2000s that we're getting the most aspects if we do place the preoperative traction, and we're getting the most benefit within the first 7 days of our tractioning. Certainly, intraoperative traction adds or enhances to our ability to allow for soft tissue relaxation, and also being mindful of neuromonitoring changes are also just as important, but perhaps maybe there is the obviation or for some of the 3-column osteotomies or even some of the anterior releases that used to be favorable or may obviate the need for any anterior releases. And kind of finally wrapping up, this is a patient that we had not only had a progression in the coronal plane, but also over time, unfortunately, developed an issue and a challenge in the sagittal plane, requiring some intraoperative tractioning and a vertebral column resection just to allow for the significant hyperlordosis to be slightly improved. He was partially ambulatory, so we did save him going down to the sacrum and pelvis, but I do think there is a lot of relevance, particularly for addressing these deformities with the application of the adjunct of the intraoperative of tractioning. This is a relatively straightforward traumatic case, but you can obviously understand that with the thoracolumbar trauma that we do see at the thoracolumbar junction, we can also address that both through an anterior approach or a posterior approach, and at least in our hands we utilize this in a posterior approach. But there are times, even though we have a lot of adjuncts with halo gravity tractioning, intraoperative traction, preoperative traction, and also the strength of our instrumentation, sometimes it makes sense not to to not hurt patients and not do what's unnecessary. For a patient who has a pretty profound osteogenesis imperfecta, even though there's a significant deformity that's present, she's now a little bit older than this. She's now up to 19 years of age. This was a image for her several years ago. There is benefit in just following patients over time, and if there is a concern or consideration of us making patients worse, then perhaps maybe the best thing to do is to continue to be their advocate and be a good clinician and physician. So with that, I want to thank you, and thank you for your time, and thanks for the invitation.
Thanks very much, Dr. McClendon. Great cases and a great overview of the thoracolumbar and lumbar deformities. I know that I remember from last year's presentation, you had moved away from doing type 2 osteotomies routinely. Is that still true of your thoracolumbar and lumbar deformities, or are you more likely to do those with these bigger curves?
Great question. Yeah, I think even with the utilizing the preoperative tractioning or the intraoperative tractioning, and I've even just to try to help with the pelvic obliquity using femoral traction as well. I think it's kind of been actually very helpful in eliminating my need to do a lot of the type 2 osteotomies or any osteotomies, quite frankly. I've seen that just with efficiency and even for blood loss. I know we had a great discussion on blood loss earlier today. It's been helpful also as far as minimizing the blood loss and the need for transfusions as well by not doing those type 2s. But it really just depends on patients' expectations and what the goals of the operation. I think it's been quite favorable. I've actually been quite impressed as well with some of the minimally invasive techniques, and so finding the right patients to actually employ that, because the blood loss is even substantially reduced if we can actually try that for some of the pediatric patients just based on the magnitude of correction that we can get with some of the MIS techniques. I think that may lend itself very favorable as well. Dr. Berman, thank you.
Yeah, Jamal, terrific spectrum of cases that you showed there. A lot of neuromuscular deformity. And what are your thoughts about the ideal amount of lordosis to create in a neuromuscular patient? And so specifically, thinking about trying to get maybe a little bit of a lower pelvic tilt postoperatively to preserve the sacral ulceration.
Yeah, thank you. It's a great question. So a lot of the patients that we see with our cerebral palsy, or even the more commonly the myelomeningocele patients, have a very, very high pelvic incidence. And so how we adjust the hip pads is quite important to actually match the amount of lordosis. I haven't really gone into actually changing the pelvic incidence as much. I do think that the intraoperative femoral tractioning has been helpful. If there is a way, if I am allowing for fixation to the pelvis, to change at least part of their pelvic tilt, but I am going to have to definitely make sure that I increase their lordosis during that time. But it's a substantial challenge that I've run across.
Yeah, I just wonder if it's worth actually trying to even exceed the pelvic incidence to try and maybe end up with these patients putting a little more weight on their ischium.
Yeah.
And so trying to get excessive amounts of lordosis to put more weight on the ischium postoperatively. I don't know the answer.
Yeah, it's a very hard thing. I don't know if you've actually used the femoral traction to try to help as well, but I have at least tried it, but I'm not sure that that's the right answer either.
Yeah, I think femoral traction certainly helps with obliquity, but in terms of sagittal alignment,
Right.
I'm not sure it helps that much.
I don't know. Great, thank you.